Hello, my dear doctors. So, today I will talk a bit about the Mrcp, which is cardiology station, and today I'm going to discuss about the prosthetic heart valve. There's a high chance that you come across this patient in your cardiology station, patient having some valve replacement. So, we'll start our presentation. Uh, First of all, once you enter the cardiology station, it's very important to look around and look for any clues. No need to rush, just take good 30 seconds to take a look at the patient, and sometimes the diagnosis will be there. If you're looking at the patient at the end of the bed, you may hear a click, and if you hear a click and you see there is a midline sternotomy scar, your diagnosis is quite obvious. Okay, so moving on, once we have done a general inspection, we like to check the patient pulse, and obviously in the pulse you want to look at the rate and the rhythm and the character of the pulse. Moving on, we will do the inspection, and inspection we will be looking at the scars. Maybe we have a sternotomy scars like we see in this patient, midline sternotomy scar. Whenever you came across midline sternotomy scar, very important that you look at the legs of the patient to look for any vein harvesting scar. Another important thing is look for a lateral thoracotomy scar. And lateral thoracotomy scar can sometimes you can see on the left side. And if you see the lateral thoracotomy scar and the patient has a midline sternotomy scar along with hearing some clicks, most likely it is a mitral valve replacement. And you know that these lateral thoracotomy scars are because of the minimally invasive surgery, and it can be it can indicate that can be mitral valve stenosis to start with. Maybe have some done mitral valvotomy or any minimally invasive surgery, and after that it has led to maybe mitral regurgitation or maybe restenosis or something that ended up with the mitral valve replacement, as is evident by the midline sternotomy scar. Okay, then after you have done your inspection, then we move on to palpation. So palpation, we want to do the check for the apex. Very important that you localize the apex beat and show the examiner that you are doing it. Normally the apex beat is in the fifth intercostal space in the mid-clavicle line. So if the apex beat is displaced, you must mention it. Maybe displaced if the patient has displaced, you say that it is displaced to the anterior axillary line, and most likely if the apex beat is displaced, then these are most likely regurgitation. And regurgitation can be either mitral valve regurgitation or aortic valve regurgitation. Okay, and then you have to palpate for any heaves and thrills, and following that you'll do your auscultation. I will not go into more details about how to auscultate. I think I have to make another video about the proper examination of the cardiovascular system. So but while you are auscultating, suppose you start with auscultation at the apex, at the same time feel for the carotid pulse, and if you hear a click which is coinciding with the carotid pulse, most likely the patient has a mitral valve replacement. And if you hear a click just after you feel for the carotid pulse, just after the carotid pulse, it's most likely aortic valve replacement. Then moving on, how you'll do the presentation of the patient. So there are three components for the presentation, and presentation is very important because if you've done a good presentation, the examiner will ask you just maybe one or two questions and you'll be done with the station. So first of all, you must mention that the This, if the age is mentioned 60 years, 70 years, you say this patient has 60 years or 70 years. Not mentioned, maybe middle age or a middle aged patient is comfortable at rest. On examination, you will do the presentation in the same sequence as you done your examination. So on examination, the pulse is regular or irregular, or how is the character of the pulse. If you find any abnormal character, you must mention. And then moving on to inspection, you say that on inspection the patient has a midline sternotomy scar, and sometimes you may see some small scars. Usually these scars, these are the drain scars. So you say that the patient has a midline and some drain scars. If there is lateral thoracotomy scar, you must mention it. And at the same time look at the legs for any vein harvesting scar. And then second thing, you'll on palpation, you'll feel for the apex, and you mention that the patient apex beat is displaced or not displaced. And on auscultation, the patient has a metallic heart sound which is coinciding with the carotid pulse. So most likely patient has a mitral valve replacement, or if it is heard after the carotid pulsation, then most likely it is aortic valve replacement. So this was all about your first half of the presentation. Then the second part is you must mention about the important negatives, and there are not many negatives. You must mention that whether the patient has any signs of infective endocarditis or the patient has any signs of heart failure. If you find any purpuric rashes, something like this, then it's worth mentioning it that the patient has purpuric rashes, likely because the patient is on anticoagulation, and that is because of the valve replacement. Then third part, you will say, so this was the first part, then we have a second, and the third part is you will say that I like to complete my examination by taking a full history, full set of observations. I like to do the urine dipstick. If this scenario suggests patient has any fever or patient is unwell, then you like to do the blood cultures as well, full blood count to look for any signs of infection. And you like to do ECG, which is very important. It's a bedside test, and be looking for any abnormality or any arrhythmias, any ischemic changes, and like to do the echocardiography, which will confirm your diagnosis, and chest X-ray as well to look for any signs of heart failure. And sometimes you may see prosthetic valve you can see on the chest X-ray. So this is how you're going to do your presentation. Start with all the positive findings, mention about the negatives, and then you say I like to complete my examination by doing this. There are not many questions they will ask if you came across the patient with the prosthetic heart valve. They may ask you about how you'll manage the patient. So again, you have to be systematic, and we divide it into like, first of all, if the patient has symptoms, you say I like to manage the patient symptoms first. And how you'll manage the patient symptoms, if the patient has fluid overload, you want to treat the patient with the diuretics and with the AC inhibitors. And if the patient has an atrial arrhythmia like atrial fibrillation, you want to go for the rate control or the rhythm control strategy. So that is a separate topic. Sure, I will do another presentation on the atrial fibrillation as well. Then obviously you have to refer the patient to the cardiology, because you want to do the further tests like echocardiography to confirm your diagnosis. And all patients with the prosthetic valves, they need long-term follow-up, and we have to anticoagulate the patient if the patient has a prosthetic heart valve. And sometimes they ask about the what will be your target INR. So remember, for the aortic valve replacement, the target INR is 2 to 3. For mitral valve replacement, it's a bit higher, from 2.5 to 3.5. Another question they can ask about is what are the pros and cons of mechanical and tissue valves, and this is quite simple. We'll say that if the mechanical valve, the advantage is it is about durability, it lasts longer, but the disadvantage is patient has to be anticoagulated and patient has to be put on the warfarin. It needs regular follow-up, and the warfarin has all other disadvantages, like patient have to avoid certain types of foods and certain types of antibiotics. So that is a major disadvantage. Tissue wall, the disadvantage is that it doesn't last longer. So normally it will last for around 10 years. It's okay for the elderly patient, and sometimes the tissue walls is preferred in the pregnant patients or young patient who will like to become pregnant in future, because warfarin, you know that this is teratogenic. So in those patients is also an option of the tissue wall replacement. Then the very common question they ask is, because we are in the hospital scenarios, we receive the calls maybe from the surgical department, orthopedic department, that the patient has a valvular heart replacement. So, and the patient is going through major surgery like total hip replacement. So remember this, that many institutions, they do have a bridging policy. So just say that I'll talk to my senior, or I'll talk to my consultant and do the bridging policies, and follow the bridging policy for the anticoagulant. However, just to give you a rough idea for generalize, if the patient is going through any major surgery, we stop the warfarin 1 week before the surgery, and we start the patient on the low molecular weight heparin. And once we stop this low molecular heparin a night of operation, and we again restart warfarin about after 1 to 2 days. But remember, even if you don't remember all these details, it's okay, as long as you mention that you're going to talk to somebody about the bridging policies and do it. Okay, so I think that's it. That's all about the prosthetic heart wall. My idea is to give you brief, to the point knowledge which will be helpful in your PACES examination, and so you can get through easily and don't waste your time on going on too much details and reading many books about this. Okay. All right. Thank you very much, and I will continue my presentations for the for the cardiology station PACES, and will give you some tips about, because there has been some queries about part 1 MCQ, so that one also we'll talk later. Okay, thank you very much, guys.